Good afternoon and welcome to our fourth Fireside Chat in this series. Thank you so much for joining us today. I'm Kristin, the CEO of Hopeful Horizons, and today I'm joined by a few staff. Just to point out at the beginning, we have Erin Hall, our Chief Development Officer, and Pam Wentworth, she's our Fund Development Associate, on the call with us. Erin is going to be monitoring the questions that you all are putting into the chat box. And before we speak with our guests today, I just want to give you some updates on what's going on at Hopeful Horizons. We are actually sheltered at capacity right now. So we are housing a total of 24 women and kids. And actually we're at 11 women and 16 children right now. We have a couple people, mom with 2 kids who are putting up for a couple nights, but our capacity is 24. So we are full up with sheltering right now. So that means if we have any other survivors of domestic violence who are needing emergency shelter, we're going to work with them to find alternate placement, or we can put them up for a couple nights while we help them find longer term solutions, which could include providing transportation out of the area to another safe place to be with friends or family, and other problem solving things like that. So again, we've continued to maintain our 30 to 35 calls on our support line each week. We are still averaging 5 forensic interviews per week, although we are starting to see that number potentially climbing up. We'll be talking more about that in a few minutes. And our counselors and therapists are continuing to provide services remotely for the most part. And they do have some clients who they're working with in person. Again, we'll talk more about that soon too. So, and our prevention education programs, we're doing more and more online and working closely with the school districts to be able to do more online with their students starting when school is starting this fall. So we're really excited about that. So things are moving forward. We're hanging in there. We're doing well. So now I have the pleasure of introducing today's guests. With us, we have Marian, who's our Children's Advocacy Center, or CAC, director. And we also have Angela, and she's our Director of Clinical Services. So I think I'll start by introducing Marian, because we'll be talking to her a little bit first, and then I'll come back and give a longer introduction for Angela. So Marian graduated from Francis Marion University with a BS in psychology. She has over 30 years experience in criminal justice and victim service fields. She's a former probation officer and served as the Director of Victim Services for the South Carolina Department of Probation, Parole, and Pardon Services. Marian has been with Hopeful Horizons for 10 years this year, yay! And is currently serving as our Children's Advocacy Center Director. She's a past board member of the South Carolina Victim Assistance Network and currently serves on the board of directors for the South Carolina Network of Children's Advocacy Centers, which is a member organization that Hopeful Horizons is a part of within the state of South Carolina. So thank you so much, Marian, for being with us today. So can you start off by explaining what a Children's Advocacy Center, or CAC, is?
Sure, thank you. And it's good to see everyone today. So the goal or mission of a Children's Advocacy Center, or CAC, like Kristin said, we like to refer to it, is really basically two-pronged. One is to provide services to support and services to victims of child abuse. So forensic interviews, medical exams, mental health counseling, advocacy for the family. And then secondly is to facilitate a coordinated effort amongst the agencies in the community whose role is to investigate or prosecute child abuse cases or provide treatment or services to the families of victims of child abuse. A little history. The first Children's Advocacy Center was started back in 1985 in Huntsville, Alabama, by a prosecutor who saw the need and benefit to bringing a child to a child-friendly setting, so not like a police station or an institutional government building like DSS or CPS, and then having those players, those agencies come to the child, where the child is, so that the child only has to tell their story one time. Fast forward 35 years, and we have around 950 CACs in the country. In South Carolina, we have 17. Also, another agency that we're very involved with is the National Children's Alliance out of Washington, D.C. That is the accrediting body for children's advocacy centers. So they are the ones that really set the accreditation standards to ensure that any child that comes to a CAC, no matter where they live, will receive, consistent evidence-based services during their healing process.
So Marian, Horizons is the only accredited CAC that serves the 14th Judicial Circuit, correct?
That's correct, yes.
And so typically throughout the state, in most judicial circuits, there's one children's advocacy center that serves. I know it varies a little bit depending on.
Yeah, there's one circuit that has two, but for the most part, there's 16 judicial circuits in South Carolina, and one of those actually has two.
Wonderful. So can you talk a little bit about, you mentioned the fact that with children's advocacy centers, it provides the space for children to only be interviewed once instead of having to tell their story over and over again. So can you talk more about what a forensic interview is, what triggers a forensic interview, how someone might come to Hopeful Horizons for a forensic interview?
Sure. So when law enforcement and/or DSS receive a report of child abuse, then they contact our intake coordinator to schedule an interview. And a forensic interview itself is really just a structured interview designed to gather information in a non-leading way, conducted by a professional who's had training in specifically in forensic interviews. So all of our forensic interviewers at Hopeful Horizons are licensed clinicians, and they have all been to the Child First training in Columbia. Child First is a nationally recognized model for conducting forensic interviews. And so when they come to the center, and the day of the actual interview, then the forensic interviewer and the child will be in one room where the interview is being conducted and recorded. And then law enforcement and DSS will be in a separate room where they can watch the interview live on a computer screen. And then typically at some point during the interview, the forensic interviewer will come out and take a break during that interview and come out and talk to law enforcement and DSS to see if they have any further questions they want to ask or any clarifying questions. So right now, we are just doing the interviews at our Beaufort location since COVID-19. But in normal times, we also conduct forensic interviews at the Victim Services Center in Advocacy. So our forensic interviewers go over there and conduct the interviews. And then hopefully soon we'll be also conducting them in Walterboro.
Yes, we're very and can you talk a little bit about forensic medical evaluations too, Marian?
Yes, forensic medicals also are done at the request of law enforcement or DSS during an investigation. So again, they would contact our intake coordinator to get that scheduled. But it's really a comprehensive head-to-toe exam of the child, and it's conducted by a pediatric medical provider who has specific training in child abuse. For Hopeful Horizons, we have Kristin Dalton, a nurse practitioner who has over 15 years experience and training in child abuse. And during the the exam, the goal is to, of course, you'll be assessing to see if there are any possible signs of child abuse or neglect. But there's also a couple of other reasons that we do the exam, and one is to ensure the general health and well-being of the child, because oftentimes these kids haven't been to the doctor for a while. And then also to ensure the child that their body is okay Particularly with sexual abuse victims, the child is really concerned and worried about that now that they've been abused, that something is wrong with their body or will be wrong with their body. And so it's reassuring to them to hear from a medical person, that your body is okay. And then also, if we get, or law enforcement or DSS have any cases where the sexual assault is recent and we require an acute sexual assault exam, which we commonly refer to as a rape kit or a safe kit, then we would refer those to Heather Dollar, who is the pediatric SANE coordinator at the Victim Services Center, to do those exams. And if Heather happened not to be available, or if the child maybe was in Walterboro or closer, they might be referred to MUSC. But in general, we would refer those to Heather at the VSC.
And so when you say acute Marian, we're looking at a time frame of maybe up to 48 hours or so?
Usually, depending on the age of the child, but it could be like 72 hours is the general term.
Mm-hmm. And would you say most of the kids who we were talking the other week about sort of statistics and the breakdown, since we're working with kids who are victims of sexual abuse, physical abuse, neglect, maybe they've witnessed violence or had some other trauma in their lives. Can you give a sort of a general breakdown of those types of cases between the different types of abuse and neglect that we might see?
Where are you asking about numbers or just in
percentages?
Percentage, yeah, and that's a good point too, because the first CAC and most CACs for 20 plus years, and even a few still today, it's sexual abuse. They were started for sexual abuse cases, but that has expanded out now to most of them for physical abuse and neglect. So the sexual abuse is still pretty much the highest, around 50%. And then that's closely followed by physical abuse, unfortunately, for all of these. But we have seen a good many where there's also witnessing acts of violence, whether it's interpersonal violence in the home, but also they may be witness to a homicide. So we get quite a few requests for that as well. I'd say those probably are like 10 to 15%.
And Marian mentioned the multidisciplinary team and the fact that we work very closely with, of course, Department of Social Services, law enforcement, school districts, guardians ad litem, other youth serving organizations and professionals, and coordinate, bring these groups together on a monthly basis to review cases and to try to make sure there's wraparound services for the child and family to have the best case outcomes in those situations. And also, since we are with the forensic interviews and the medical evaluations, we're actually gathering evidence, right, that can be then used in the prosecution of cases, and provide expert witnesses as well. Marian, do you want to say anything else about our role with MDT and with, prosecution and all of that?
So, and just to touch a little bit about the evidence. So the rape kits that we talked about, that's definitely, gathering evidence, but the medical exams, you'll hear the medical providers that talk about doing the comprehensive medical evaluations. Rarely do we have findings in sexual abuse, because usually that's, it's happened weeks before or sometimes even months before when the child discloses. But we do, it's really critical, like in physical abuse cases, for Kristin or a medical provider to see these kids so that they can document the injuries and testify in court about how it could be this and it couldn't be that, because oftentimes, the parents will say it happened this way, or whoever the alleged offender is, and a medical person can come in and say it really couldn't have happened that way. But yes, we do. We're fortunate to have an MDT coordinator at Hopeful Horizons who, like you said, does organize the monthly case reviews so that we all can get together and talk about the cases and share information. And so that, that's DSS, law enforcement, the solicitor's office. We have someone from the schools represented there. But so that, the goal, of course, is to make sure everybody's on the same page, the best way that we can help these children and families, but also move forward with prosecuting the case if it's possible, and making sure no kids fall through the cracks.
Wonderful. Thank you. So I'm going to shift over to Angela, but of course, Marian, you can jump in and add to anything that we talk about with Angela as well. So my intro for Angela is a Low Country native who joined Hopeful Horizons team in 2016, first as a therapist and currently as our clinical services director. Prior to working in mental health, she was a middle school English teacher and guidance counselor for 8 years. She earned a master's in professional counseling in 2010 and made the transition from teaching to full-time mental health work in 2013. Angela's worked in multiple mental health settings, including in-home family therapy with youth involved in the juvenile justice system and in a psychiatric residential treatment facility for children and adolescents. So Angela is passionate about working with trauma survivors, mentoring new therapists, and rescuing animals. So thank you, Angela, for being with us today. So to start off, is there anything that you want to jump on and add to with what Marian's already talked about before we get into some Angela-specific questions?
Erin, I don't know if you want me to do the question in the chat yet.
How did you know I was going to save that for you? Go for it.
So I think first, thank you everybody for being here. And just to give you an overview of our team, I supervise 8 clinicians. And 4 of those are interviewers as well. And we expect to train 2 more in addition to that. So the question that was asked is, for my interviewers, is can they kind of get away from the bad stories when they go home? No, but that's part of what we do. So I don't think any child ever comes to Hopeful Horizons because a good thing happened to them. But what fuels us is the work that we do. And our clinicians, you don't come to this work by accident, and you don't stay here unless it's really important to you, because it's very difficult. For my interviewers specifically, they like to be part of the process where they feel like they can hold people accountable. So the interview process is helping to push a case forward to basically have someone who's hurt the child pay the consequence for that. And so I think that's the rewarding part, and that's where they kind of hold on to hope, and that we do see people who get held accountable or kids get placed in a safer environment because the interview happened and the kid disclosed. When they do take it home, there's lots of discussions about that. I could talk to you guys about how we tackle self-care for the next hour. I can say all my clinicians meet with me on a weekly basis for a minimum of an hour. So if it's been a rough week, sometimes we've gone into 2 hours because they need to process and they need to have a safe space to talk about how they're feeling about what happens. And then we have a really generous time off policy, and we try to strategically use that for times that they've had difficult cases, and maybe you take a day off, or maybe you just need a break for a long weekend. So yes, we take stories home with us, but that's not always a bad thing. It kind of fuels why we do what we do. And we don't just take the bad stories home, we take the successes when we see kids get better, and when we see people pay the consequence, and when we see kids stabilize. And for us, the good outweighs the bad, or we wouldn't be here. So.
Thank you, Angela. So can you talk more about what happens in therapy, what treatment modalities we use?
Sure. What we hope happens in therapy for our kids is a lot of fun. So the subjects that we talk about are very difficult, but we try to approach it in an age-appropriate way. So for a little kid who's 4 or 5, you're going to see lots of games and lots of, glitter bottles and slime and belly breathing, and really teaching coping skills in a way that's fun for those kids. But for our older kids, you may see us, we're going to go for a walk and talk about what happened, or we're going to listen to your favorite song and talk about how those lyrics impact how you're feeling and how you can use music as a coping skill. So we really try to individualize it to what the kids are doing. And, we do this every day. So we also want to have fun, and we want to play while we're together, while they're learning skills. So the biggest treatment we use is called trauma-focused cognitive behavioral therapy. So all of our clinicians go through a year-long learning collaborative to make sure that they know how to do this model. So it basically just starts with educating kids about what trauma is and how it could affect them. Very normalizing for a child to say, like, you're having nightmares, and do you know that lots of kids who go through bad things have nightmares? So that we call that the psychoed piece, and that really just helps kids to feel that they're not alone, and also to educate parents on what to expect and to not freak out if you see this, because this is kind of a symptom we're used to seeing. And then we go into relaxation skills, which is where you see all the fun and the bubbles and the belly breathing that we enjoy. And then we go into effective expression, which is simply helping kids connect language to how they're feeling so that they can convey that to other people. So learning that, okay, the feeling I'm having right now is anxiety. And when I feel this, if I do the belly breathing, we do a lot of belly breathing. If I do that, it makes that feeling not so big, and I can control it better. And then I can also tell my parent or my caregiver, hey, I'm feeling this, instead of just having feelings and not really knowing how to identify them. And we also find that it's helpful to some caregivers too, because we don't always know how to put language to what we're feeling. And then we go into the kind of cognitive component, where we teach them how your thoughts and feelings and behaviors all kind of interact with each other. So if I am feeling tired and I'm having thoughts like, I don't want to do this anymore, my behavior may come across as a little grumpy. And so we kind of help them to link those, because we also want them to link their thoughts and feelings about their trauma. So once that component is completed, then they go into their trauma narrative. And a lot of people think this is about them telling their story. It's not. It's really about putting puzzle pieces together and helping them realize what triggers them. So if you tell me that a unicorn came in during your trauma, I am not going to question that, because I'm not trying to find any evidence. I'm not on a fact-finding mission. I want to know how you felt, what you were thinking. Was there a smell that we need to be aware of that you kept seeing? Basically, what was going on in your mind and body, because those are the things that are going to be cued later and trigger you. And those are when the big feelings are going to come. So we go through the narrative and we process that, and then we share it with a supportive caregiver. And that's when I tell you what my therapists take home, they take home those sessions, because it is a chance for a caregiver to hear what happened to the child in a safe way, and to respond in an affirmative way, and let them know this was not your fault and you're going to be okay. And the end of their narrative is always this really cool place where they give advice to other kids who might go through this and share all that they've learned. And we get cute stuff like, you can trust your therapist, or come to Hopeful Horizons if something bad happened, they'll make you feel better. That's why we stay. And that's usually the session where everybody cries, therapist included, because it's such a beautiful moment. And then after that, we really work on just increasing personal safety and healthy development. So for teenagers, that's talking about dating and safe sex. And for the younger kids, it's talking about, touch and make sure you're telling people, and really just kind of close therapy. And then that's when they graduate. So we usually check, and by that point, any symptoms they have usually decreased significantly. And we usually have some kind of celebration. And then we tell them they can come back whenever they want, because of course we're going to miss them. So that's our biggest, and we can take pieces of each component. So if the kid just needs to learn some relaxation skills, or they just need some psychoed, we can take pieces of that and give it to kids who maybe just experienced some grooming, or a questionable thing happened and we're not really sure, but we want to empower them to move forward. So we can kind of, whatever we specialize in, but that is the big thing that we do at Hopeful Horizons on the clinical team.
Wonderful. So it sounds like kids are coming into clinical services, either maybe they've had a forensic interview done and then you all do an assessment, to determine what, type of treatment modality would work best, or we might have someone who's just reaching out and needs some counseling and support and coming into services that way too. So what you talked a lot about, the skills that you're teaching the children and the caregiver. So what are you hoping then, since they can't be with us for forever and they're graduating, what are you hoping they're taking with them, both for the parent, the caregiver, parent, and the child?
The biggest thing we want them to take with them is that this is something that happened to you, but it's not who you are. So for us, that is a success. Just if they can shift their way of thinking. And I always tell them, like, it's like a scar. It will probably always be there. It's always a part of you. But what we know about scarring is that's also where you're stronger, because it's been built back up and you have that barrier. So that's kind of what we want them to have, is like, this is my scar and I'm totally okay. But we also want parents to feel, one, that they can come back anytime, good or bad, because we like to hear the good stories too. But two, we want them to have a good grasp on the skills, because kids are not going to always remember them. And as we all know, when you're upset, the last thing you do is remember what your therapist told you to do. So we need parents to be able to kind of step in and to remind them to use their skills, and also for the parents to probably use those skills themselves. So those are probably the biggest things, but we also want them to walk away feeling like what they wanted to get from therapy, whatever their goal was accomplished. Because we have our goals, like we want to see them have less symptoms, but really we want them to walk away with what it is they wanted to get from us.
Mm-hmm. And you mentioned symptoms. So we are tracking from when the child starts therapy to when they complete therapy, looking to see a reduction in symptoms related to post-traumatic stress disorder, correct?
That is correct. So we have two assessment measures that we use. So one is the CPSS, and basically that's a child assessment for the symptoms you would normally see with PTSD. So this looks at things like nightmares, flashbacks, hypervigilance, signs of depression and anxiety. And then we also do, we look specifically at anxiety and depression symptoms, because we know those go hands in hand with PTSD. And so we do a pre, we usually do one in the middle, so right before we start the trauma narrative. And honestly, we expect those symptoms to kind of go up right before we do the narrative. They're nervous, avoidance is really high with PTSD, and by that point we expect it to be down and that they're feeling a little bit more of the emotion. And then after the narrative and the processing, we usually see it drop significantly. So depending on where a kid starts, I've had kids that start with 50, and a clinically significant is 15. So they are highly symptomatic. And then at the end, they're at, like a 3. And again, we have a big party and they know their scores and we talk about them, and it's part of the process. And, them self-reporting every time they come in, kind of what's going on and what's bothering them most. So we track it kind of on a big scale, but we also track it like, if you come to me and you are having a problem with nightmares, I'm going to ask you about that every week until we see a decrease in that. So whatever it is that's bothering you the most, we're also going to track that every week to make sure that what we're doing is targeting the thing that's bothering you the most.
It's wonderful how personalized you all are able to make it. And the coping skills that you all are teaching the kids and the caregivers, hopefully that's something that they'll be able to use throughout their lives, even if they don't remember right at that moment in time. Hopefully it's something that they'll be able to draw from ongoing. And you also mentioned too with the caregivers, helping them gain some of those skills. And I know, fairly frequently we have situations where we have caregivers who disclose that they're survivors of abuse, or they've been sexually assaulted, or they're in an abusive relationship. So how do you handle those situations?
We try to offer them therapy too. So as long as we have the capacity to offer it, and like Kristin said, it happens way more often than we think. On both the Beaufort and Bluffton side right now we're treating multiple generations of families in different cases. So we'll have like a grandmother, a mom, and a kid, and they're all victims of childhood sexual abuse, because we know that these things, it's generational often. Those are the best cases, because you really get to target the entire family from all around, and you get to see so much healing at one time. You know, we're not excited that it kept happening in the family, but we're really excited that maybe this is the end of the cycle, and also that the whole family can heal together. Those are really powerful, both for the families and for us as clinicians.
Absolutely. Well, and there's a really important member of our CAC team, and your team in particular, Angela, who we haven't talked about yet. Can you talk about Adobe and what a facility dog is?
So we have Adobe, and Adobe is a very highly trained dog who was trained by Canine Companions for Independence, and given to us completely for free. And by us, I mean he gets to hang with me. So he, right now during COVID, is providing probably therapy for me most days, and then also via the computer. But he's a facility dog, and that just means that he's trained to work in a facility. He is used to the kids climbing all over him and pulling his ears, and he doesn't react to any of it, except for he might lick them. He is highly trained, so he can open and close doors, he can pick things up, but he can also just lay at a kid's lap. So maybe they had a rough FI and they want to come meet him. When we're in the office, I have frequent flyers. My office is right by the bathroom, and so lots of kids have to go to the bathroom and then wind up like stuck in my office when they're supposed to be in therapy hanging out with Adobe. And he is down the hall right now in his kennel, because he has brothers and sisters that will whine if he's out and they're not. So I can get him at the end if we would like to meet him. But Adobe basically is another clinician for us, and kids can read their trauma narratives to him if they want to practice before they share with their parents. Again, they visit him all the time. He barks on command. I think that's their favorite. And the difference between a facility dog and a service animal is that Adobe is just licensed to be with our clients. So I do not have the right to take him into a store unless there's a client with me working on a specific goal. So basically we don't have public rights, but we have rights to be in the facility.
Can you touch really briefly on the difference between a facility dog and a therapy dog?
A facility dog has a lot more training. So a therapy dog has to basically pass the canine citizenship, basically to say that they're non-reactive. But Adobe went through a year and a half of socialization training from the time he was born. And he did that with a Girl Scout for her Girl Scout project, which is always my favorite. She's also in vet school right now. So she gets to follow his life, and we're connected that way. But then he goes through 6 months of training at Canine Companions. And then I have to go through 2 weeks of training to be his handler. And then I recertified the first year and the second year, and now we have a 3-year recertification. So they keep up with us. They make sure that his skills are up and that we're doing what we're supposed to be doing. There's a lot more that comes along with a facility dog than just a therapy dog.
Absolutely. Well, you know, Adobe, I do think, is for some reason everybody's favorite Hopeful Horizons team member. So he's definitely the cutest for sure. And probably the most chill.
Yes.
So Marian and Angela, is there anything else that we haven't touched on or that you want to go back to talk about a little bit more?
I was going to, as far as Adobe, I was going to say, yes, it's the clients. He's great for the clients, but the staff love him. And also our MDT partners, when they come, they love to see Adobe as well. So he's just serving a lot of us, right, Angela? So, but one thing I wanted to go back to, Kristin, that I think you asked me that I didn't address, but when we were talking about forensic interviewers and testifying in court, which of course the forensic interviewers do when the case goes to court for prosecution. But also if they can be, our therapist can be a blind expert if they didn't do a forensic interview or don't know anything about the case. So that also helps with the prosecution. So what that really means is they can come in and talk about the dynamics of sexual abuse and recantation, because oftentimes a child may initially disclose and then come in the forensic interview and not disclose, or vice versa. You know, they're in the interview and they disclose, and then later on they what we call recant. And because once they realize, you know, of course they just want the abuse to stop, but then they realize all this chaos in their life that it's causing by now them coming forward, you know, they want that to stop. So anyway, our therapists can go in the courtroom and explain that to juries, and that's also helpful with the prosecution. And then, you know, we talked about the forensic medicals and the interviews and medical exams, but I also wanted to talk about the family advocacy piece, because we're very fortunate to have 4 family advocates at Hopeful Horizons, and they're really the point of contact for the families, and they're at the forensic medicals and the forensic interviews to be with the families and to, you know, educate them about the process and support them along the way and kind of let them know what the next steps are going to be. They do the referrals if it's decided that the child could benefit by having an intake and assessment and treatment, then they do the referrals to send to Angela, who assigns them to the therapist, and any referrals really that the family might need. So the advocates and the therapists work really closely together. Angela's team and our team all meet together weekly. And so I just wanted to make sure I brought that up, and also talk about, like, any caregivers, you know, just a shout out to reach out to our support line. You know, of course, if you have concerns about abuse, you certainly can and should report it to DSS or law enforcement. But if you just have some concerns you aren't sure about or want maybe support to help you in making that report, you know, please reach out, and a family advocate can help you with that.
Absolutely.
Yeah.
I would like to echo how vital our family advocates are for us. So not only because we work so closely together, but there's always an advocate assigned with an interviewer. They're always hearing the same story from the kid. And they really lean on each other. So there's nothing like the shared experience and not feeling like you're so alone and having to carry the interview by yourself. Like, your advocate's always there. And if you need to close the door and cry after everybody leaves, like, you have somebody there with you to process through and to see the case through. So we do what we do, but they definitely keep us running a lot of the time.
Well, it's so important to have, like we're talking about with MDT and with therapy, making sure we're providing those wraparound services to support the family, the non-offending caregiver, you know, since the kids are only with us for a very limited amount of time and the families are only with us for a limited amount of time. We want to be able to give them the tools and skills and support that they need in order to move forward. Do you all have a sense of how frequently someone, a former client, might come back into service for like a booster session, or, you know, just to check in?
I don't have the actual number. That would be a good thing for us to track. But I can say probably at least a quarter of our clients wind up coming back at some point, which is a testimony to the relationship that we've created with the caregiver and with the client. And sometimes it's stuff that we can't help with. It kind of goes beyond the scope of treating the trauma. But they trust us enough that they're going to come back and say, like, I don't know my next step. I know I need help with this, and I trust you. So can you help me get where I need to go? So we don't always see them when they come back, as far as see them again for therapy, or we may only see them for a session or two before we realize, hey, you know, family therapy is probably where you need to go. And, you know, this isn't necessarily what we are experts in, but we're going to get you to the right place. And then sometimes it's, you know, I was 8 when my abuse happened, and now I'm 13, and I'm I like boys and I'm confused about some things and I need to come back and chat about that. And those sessions, again, are also what keeps us here, because we want to hear your progress and what's happened and kind of help you face the new phase of life. And we do this because we care, so we miss them sometimes.
Absolutely. I would echo that, Angela. And one of the things I was just thinking about that I'm always most proud of is the surveys that the advocates do, follow-up surveys afterwards with the families. And one of those questions is asking about if you knew someone that this happened in their family, would you recommend them coming to Hopeful Horizons? And it's always in the 95 to 99% range of yes. And so, you know, that is definitely rewarding for the advocates and the agency.
So what would you say separates out Hopeful Horizons clinical team from, like, say, Coastal Empire or private practitioners?
I mean, personally, I think I have the best therapists in the world, but I think part of it is just our specialized training as well. So, you know, if I'm having a heart problem, I don't want to go to a general practitioner. I want somebody who knows the heart and can treat what's going on with me. And I think that's our advantage, is we don't try to treat everybody. Like I said, sometimes we have to refer out because this is not the area that I know I'm an expert in. But when you come to us, like, you can know that we understand trauma. We understand the systems that are going to impact you. We work with your school. We work with DSS. We work with law enforcement. So when you get us, you don't just get a therapist, you get an advocate, and then you get all of our connections that come together. So that's the advantage of coming to us as opposed to somebody else. But we're also free. And that is, I mean, I can't even put words to how much that means to us as clinicians, that I never have to say, well, you reached your insurance maximum and you need 10 more sessions, but I can't. Or you need a 2-hour session today, but I can't. We never have to say that. I never have to say, you know, you can't come in until next week because of a billing issue. Like, just come through the door. Come in. We're going to treat you. We're going to treat you for as long as you need, whether that's time or whatever. So that's also an advantage we have, that people outside of the agency don't always understand how freeing that is.
Wonderful. Do we have any other questions? Does anyone else have any other? Erin's nodding.
Yes, we do. Of course, there's a question about Adobe. So how old is Adobe, and can he be a facility dog for his whole life? Is there a start and an end to that?
So Adobe is a little over 4.5 at this point, and there will be a time where he goes part-time and he retires. But that is based on Adobe, and because he's a facility dog as opposed to a dog who's actually doing all the skills that, like, he doesn't open doors all the time or pull wheelchairs. He really just kind of hangs out and loves on people. The average is about 10 years, but he could go longer depending on his health and where he's at. My goal is to keep him working for as long as possible, but that's why we do, when he's getting older, we'll go back every year for them to reassess. And when he's getting closer to retirement age, they'll work more closely with me to see what's going on with him.
That's great. I have one other question, and that is, for both therapists and the family advocates, what does a good day look like? I know that's a hard question.
Do you want pre-COVID or both?
Oh, I think both. That's a good point.
I think in either place, like, them staying busy is always a good thing. So they don't like to be slammed back to back to back, but having a good 4 or 5 clients a day is normally a better day than when you have a couple of cancellations. A good day really is any day that you see any kind of progress.
Absolutely.
Or learn something new. And they have bad, I mean, like, we deal with some heavy stuff. They have bad days. So defining a good day sometimes also comes down to your attitude.
Yeah, and like Angela said earlier, we all have each other to lean over, but particularly the therapists and the advocates do that together. And after hearing, because you're right, somebody mentioned about the interviewers hearing that, but the advocate is also, I think I neglected to mention that earlier, but also in that room with the investigators hearing all of that as well. So, but yeah, but we do get to hear the successes, and that makes it all worthwhile.
Yep. You have another one, Erin?
Yes, sorry. How many forensic interviews does the team typically do in a week? And again, pre-COVID and currently might not be the same answer.
Yeah, during COVID right now, I think we're averaging around 5. And before that, it would have probably been about 8. In 2019, we did 385 FIs. I looked at the period of January through June 2019 and compared to now, make sure I get this right, but in 2019 from January to June, we did 175 interviews, and for the same period in 20, we did 151. So it is down, but it's not as significantly. That is the one service that we have obviously continued to do in person, but it's, in the beginning, there was a lot of, when COVID broke out, there was a lot of, the reports to DSS were definitely down, but they are seeing an uptick in that, and definitely law enforcement as well. So, and the medicals also were down a little bit too. And in the beginning when it first broke out and we didn't have the PPE supplies and everything, and so we just started saying, we can only do it for emergency cases. For a month or 2, 6 weeks in there, we were just doing emergency FIs, but really back since probably mid-May, I would say we've been doing quote unquote routine interviews.
Wonderful. Okay. Any other questions? Oh, yep. Got another one.
I have one more question, and let me make sure that I say this correctly. Okay, sorry. Had to make sure I understood it. Would it be helpful for Hopeful Horizons if there was more than one facility dog, or is Adobe's capacity where it is he good? What does Adobe need? Does he need a friend? But seriously, what if there were more facility dogs? What would that mean for the organization?
That's a big question. I mean, you're talking to a true animal lover. So Adobe's one of 4 dogs, and he also has 2 cat siblings. So I say the more the merrier. I would say the process for Adobe is quite labor intensive. And so he does come to us free of charge, but it was 2 years of my life that I committed to the application process. And it's very thorough because when he comes to us, he's completely free. The training I received, where I stayed for the 2 weeks, was free. But also, for me, he's my pet. And so like I pay for all of his flea meds and food. He's just part of the family. But if we were to commit to more dogs, like you would have to have a person who's willing to commit to those expenses. Sea Island Animal Hospital does provide for his vet care for free, but that doesn't mean if we had 10, they would do the same thing. So I would say yes, like we can always use more facility dogs. And I think with different locations, like it would be great to have more. And Adobe loves everyone. So sure, he would love some more of him around. But it's just quite a process. And it's also, it's a commitment on my end. So they still hold ownership of Adobe. I'm basically like his adoptive mom until he retires. So he is not fully mine because they carry his insurance. So I also have to be committed to working at a nonprofit for his whole life, or I could lose him. So you also have to be very careful about who you select because they have to be in it to win it, I guess.
Wonderful. Okay, well, Thank you so much, Marian and Angela, for taking the time to talk to us today. Is there anything else you want to share that I didn't ask you about?
I'm gonna go get Adobe.
Okay, yeah, go get Adobe.
Yeah, good idea.
Up so that everyone knows that he does exist and can see how wonderful he is.
That's right.
And the Bluffton office will put in a request. If there's another facility dog, we'll be happy to have him in Bluffton post-COVID.
Yes. Yes. Oh,
Are you volunteering to be the facilitator, Erin? Sounded like a volunteer.
there he is.
Oh, there's a Debbie.
Gonna stay. Come on, Adobe, up. Good boy. Sit. Speak. Speak. Quiet. Good boy. Hopefully y'all could see him. I tried to get him on the couch.
And we heard him.
Yeah.
So like Angela mentioned, you know, all of our services are provided free of charge. And again, that's thanks to you all. Because of your support, we're able to do that. So we're so grateful to you all for your support. And again, if you haven't had a chance to donate this year, you can go to our website, hopefulhorizons.org, and make a donation today. Hopefully we'll get to see you next week. Next week is our final fireside chat in this series. We're going to be talking to Jean Regala, a retired FBI behavioral profiler, about common traits of individuals who perpetrate domestic violence, sexual assault, stalking, all of those sorts of issues that we've been talking about. So it should be really interesting. Hopefully you can join us for that. And great to see you all. Thank you so much. I hope you all take care and stay safe. Have a good afternoon.